Welcome to Maastricht, heart of Europe and a hub for healthcare innovation. Located in Limburg, the gateway to Europe, Maastricht blends a rich history with forward-thinking solutions. Here, Maastricht University, MUMC+, and Brightlands campus unite to transform healthcare through cutting-edge research and collaboration. Join us at the ICT&health World Conference to explore hands-on solutions on AI, digital care, and interoperability. Connect with global leaders, experience groundbreaking innovations, and enjoy Maastricht's hospitality and charm. Shape the future of healthcare.
Good morning, ladies and gentlemen. Still going on and coming in. Very nice that you are here. And like yesterday, a full house. Great. Today we start with a special guest, the Minister of Healthcare in the Netherlands. She had a career in the second chamber of our parliament and always dedicated to healthcare. And now she is on the steering wheel and she knows that there are a lot of problems to be solved. And she wants affordable and accessible healthcare, of course, we all want to have that. But for her it's also important that it's future-proof, sustainable. And she's concerned about the shortage of healthcare workers. And maybe she hopes that all the digital innovations we discuss here might have a solution. Might have, because she is aware that you don't pick something from the shelf and it will be solved. Ladies and gentlemen, Fleur Agema.
Good morning, everyone. It's really impressive to see so many of you here together. And I'm pleased you've found time in your busy schedules to attend this conference today, because important issues are at stake. The continuity of our healthcare system is already under pressure, and this challenge will only grow more urgent in the future. And before I talk about that future, I'd like to take you back in time, to the dawn of the electronic age, in the Second World War, to Bletchley Park, not far from London, where decoders worked day and night to decipher the coded messages that the Germans were sending to their submarines. That was difficult, because the Germans had an encryption machine, the Enigma, whose algorithm changed every day. The British had pencil, paper, and the brilliant minds of the country's best code breakers. But no matter how hard they worked, progress was too slow. That's why a group of mathematicians led by Alan Turing worked in the deepest secrecy on a machine that could be used to decode those messages. It was easier said than done. Setback followed setback. The project was in danger of being stopped, until Turing, by sheer coincidence, found a solution to the problems he was facing. Suddenly, his machine could decipher messages at lightning speed. Suddenly, they knew exactly where the German submarines were and what their targets were. In hindsight, this moment became a turning point in World War II. Historians estimated Alan Turing's machine, the very first computer, may have shortened the war by 8 to 10 months, changing the lives of hundreds of thousands of people. And since then, ICT has continued to change lives in many different ways. The functioning of our society and our healthcare system depends heavily on ICT. It supports healthcare professionals as well as patients, clients, informal carers, and the public at large. Healthcare is and will always be human work. But ICT offers us the countless ways to optimize this care. For example, patients can measure their blood pressure at home and share it with their doctor using an app. So they only have to come in for a checkup when it's really necessary. And home care services can send patients digital reminders to take their medication, so that nurses have more time for other tasks in their busy schedule. ICT offers many more possibilities, and we must harness them in order to safeguard the quality and accessibility of healthcare. This means we need to change the way we work, here in the Netherlands and in the rest of Europe. The effects of an aging population and becoming apparent everywhere. There are more people with care needs, yet there aren't enough professionals to provide this care. Waiting lists for elder care are growing. It's not always possible to see a GP right away, and people are having to wait longer for mental health care too. Sometimes scheduled treatment is compromised, and I fear that soon emergency care might be at risk of this. And all over Europe, people are working to prevent the healthcare gridlock. Yet we all feel that our efforts are not enough, that we need to shift up a gear, that we need to develop and implement solutions now, solutions that we've been talking about for far too long. Artificial intelligence, an idea that Alan Turing also explored, can help us with this. I even think it could be a game changer. Used properly, generative AI can reduce some of the administrative workload. For instance, it can summarize doctors' notes and manage medical records and reports. Doctors can use speech recognition to compose a handover report and add it to the patient's record. The potential of digital healthcare and AI is truly exciting, but there are still many questions. The challenge is to seize the opportunities and mitigate the risks. How far can we go without losing direction and control? How can we safeguard the privacy of patients and clients? How can this technology support professionals while also increasing their job satisfaction? How can we use digital healthcare and AI effectively to ensure they have real impact? How can we scale up solutions quickly and safely with limited capacity? All questions that need answers, answers that apply internationally, because this is a prime example of a development that knows no borders. Beyond these questions, we need to take a good look at our own efforts. Too often, innovation is something that we do on the side, when in reality it should be integral to our work. After all, innovation also means letting go of the old. And that's something many of us struggle with. There's also too much reinventing the wheel. The not invented here syndrome is well known in healthcare. That's why I hope you'll use these 3 days in Maastricht to learn from each other about what works and what doesn't. I encourage you to form alliances, to share successful initiatives, collaboration that extend beyond specific programs and projects. We must work to make innovative care the norm rather than the exception. For the Dutch stakeholders here today, if you can't wait to get started after this conference, visit the Dutch platform zorgvoorinnoveren.nl. There you'll find an extensive knowledge base, networks you can join, and coaches who can help you and your organization explore your next steps. And if change isn't happening as quickly as you'd like, please let us know, either via zorgvoorinnoveren.nl or by contacting us directly. Many staff members from my ministry are here today, and we'd be happy to help you or put you in touch with colleagues who have faced similar challenges. Government action alone can't make healthcare better, but healthcare sector parties can't do it all by themselves either. We need to join forces, work together to achieve results, support each other and challenge each other on to do better, for all those people who depend on us. When the Second World War ended, the first inclination was to keep all the details about how Turing's code-breaking machine worked a secret. Fortunately, he and others continued to build and share knowledge, sparking the real ICT revolution. Let us keep that in mind today. The innovations that we develop and implement together have the power to improve people's lives and support healthcare providers. They can free up time for what healthcare will always be about, real human attention. Let us cherish and protect that by taking action now, by cracking the code, so that we can ensure access to good quality healthcare for all patients now and in the future. Thank you.
Thank you so much. I know you have a tight schedule, so no time for questions.
Yes.
And I wish you good luck, and we will collaborate. Thank you.
Have a great day. Thank you.
She visited this morning all the different stands, so she was really very curious. And I think, not invented in my backyard, we don't do that anymore. We have to collaborate. I think that she's right about that. We have a new guest this year. It's the Antoni van Leeuwenhoek Ziekenhuis in Amsterdam. And the Antoni van Leeuwenhoek cooperates not only with all the specialists and nurses, but they also cooperate with patients to innovate. And also with vendors from outside. For instance, Kaiko, he's here also on the floor. And they try to build their own systems. Of course, with standards we have in healthcare industry and in healthcare care. But how do you coordinate such things? I'm not sure, you may correct me, but I think they have the first chief patient officer, and he's here. 3 gentlemen will come on the stage. Harry Verbunt is their chief patient officer, and he's a cancer patient himself. Richard Dirven. Please come here, gentlemen. He is the head of the neck surgeon, but he is also the chief medical information officer. And Edgar van Zoelen worked, for instance, for Philips for years, but now is their chief digital transformation officer. Gentlemen, start. And we are very curious how you organize your innovation.
Thank you very much. Let me first by starting off, and thank you all for this opportunity to share our journey. If we can put up the first slide, because ultimately what we, if that can happen, can somebody put on our first slide? Here we go. So basically our title of today was to CPO or not to CPO. And as Maria just mentioned, we're here, the 3 of us, because we would like to share with you our digital, quote-unquote, transformation journey. We would like to share with you or give you a sneak peek in our approach and our approach to drive this transformation. And one thing is very clear, that we can't do it all by ourselves. And the other thing that's very clear, that what we've been doing is not very successful to fundamentally change the way we deliver care. So from the Netherlands Cancer Institute, Antoni van Leeuwenhoek, we consider ourselves to be a little bit different. We consider ourselves to be leading in cancer care and cancer research. We're proud that we're in the top 10 of comprehensive cancer centers in Europe. So one could say we're very good at actually providing that care. But the big but is we would like to provide that care in a better and more effective way to treat more patients in an even better way than we do today. So how can we deliver this fantastic care even better? So what we did is we put the patient in the middle to really drive everything from a patient journey perspective and then drive our innovations along this patient journey. And with that we have Harry, literally how I would see it, the first chief patients officer, to really embody that and keep us really honest in doing so. So without further ado, Harry, could you please take it away?
Thanks. Yeah, I'll start with something completely different. I'm not talking about ICT, because I'm not a chatbot, I'm not a hologram, I'm not anything else. I'm a real life patient. I'm still a patient. Before I go deep dive into the CPO role, I will give you a little bit of my journey where I'm in the middle right now. And my title and the message I have for you is no one can promise you tomorrow. And that's what I have found out starting on May 27, 21. Before that time, I was completely healthy, happy. I'm married for almost 32 years, a son of 29, a daughter of 26. I was happy. I was working as a healthcare advisor in the IT industry, so I knew already a little bit of healthcare and what was going on. And I had a specific perception of how it was arranged. And in every annual review, I saw patient central. In every review, I saw it. In annual reports, I saw patient central. Until that date, where I became a patient. And when you become a patient with a complex illness like I have, and what I have is metastatic esophageal cancer, which is incurable, then you have to deal with many, many specialists. And you see that not in many cases the patient is central. In many cases the process is central. I also refer to the EPD we have in the Netherlands, the electronic patient dossier. It's more a process than a patient that is automated. When you look at my journey, it is before 27 May 21 and after. And after, and it's still going on, I'm right now in a clinical trial. I'll go into a little bit of more detail next slide. And I have a bit white raven over there because that's a special bird and you don't see them very often in nature. I'm also a special patient because someone with an illness like me is normally the forecast of your life is when you're diagnosed, it's normally 1 to 3 years. Well, it's now for me already 4 years ago, and I'm still here and I'm still relatively healthy. When you look at my milestones, and I give a link to the ICT where I was, the first diagnosis was on May 27, as earlier mentioned. It looks like it was curative. So that was no problem. And I got the chemo, the radiation, and also some surgery. But almost a year later, it became a fact that it was metastatic. So from that moment on, I knew it was incurable. Lucky for me, I did a second opinion with Professor Bob Pinedo, who is a really famous oncologist in Amsterdam. And he said, well, you're very lucky because you have a specific protein on your tumor, and it's called HER2. I wasn't aware of that because I'm not a medical specialist. I was working in IT. But no one told me that I had HER2, and he was really surprised that no one before him made me aware of that I have a special protein, because based on the protein, there's a good chance there is immunotherapy or other therapies that could extend my life. It stays incurable, but maybe it can extend my life. So he told me that there were clinical trials at the Antoni Leeuwenhoek hospital, and he said, well, I think you have to go to the Antoni Leeuwenhoek hospital. That's what I've done, and I started a clinical trial on June 22, so that's almost 3 years ago. On average, in a clinical trial, a patient is, well, more or less 6 months. I'm now already for 3 years. So that makes it very special. And along the way, people ask me, how am I doing? And how is that compared to your perspective from you were in the ICT and you're now a patient? Well, what I've done, I share my journey on LinkedIn, and a lot of patients come to me and say, well, how did you do that with the second opinion, more things going on? When you're interested, just find out on LinkedIn. So I don't go into detail right now. But thanks to that, I said, well, I've so many good things in the Antoni van Leeuwenhoek Ziekenhuis. So I said, well, if there's a chance I can do anything back to the Antoni van Leeuwenhoek Hospital, I will do that. So that's why I had a discussion with Maurice at the Antoni van Leeuwenhoek Hospital, and he said, well, we want to put the patient really in central, and we want you to give your perspective as a patient. So that's why I started just 2 months ago as the first Chief Patients Officer at the Antoni van Leeuwenhoek Hospital. And what that does it mean? What I'm trying to do is to give, on a strategic level, the perspective of the patient. We can do anything with IT, and that's also my background, but how does it reflect for the patient? Is it really good for the patient or not? But my most important mission for me, for my life, is of course finding a cure for my illness. That's number one. I'm 24/7 still patient, so that is my priority. Besides that, I want to also guide other patients. When you first start and you're diagnosed, it's really a healthcare jungle. And to find a way in that healthcare jungle, it's really difficult as someone from outside the medical spectrum. And I'm trying to put the patient central. So that's why I'm also here at the Antoni van Leeuwenhoek Hospital, but also trying to have a conversation with other people in other hospitals, put the patient central. Because it's at the end, it's all about the patient. What you are doing in the hospitals, it's all about the patient. Why are you doing something with ICT? To cure patients. So the patient must be central. And I want to be a critical mirror for a healthcare industry. So this is my story in very, very short, because we have limited time. But if you want to explore more of my journey, just find me on LinkedIn. I will give now the word to Richard, who will tell you more about the innovations where the patient, of course, is central.
Thank you very much, Harry, and impressive presentation. And it's great to give this presentation together with you. I think you really elaborated very well that everything we do at the Netherlands Cancer Institute is for patients, for you. You should be central, and with that also the patient journey. And it's very important to bridge that gap between what we need to do in the patient journey and the research that we are doing in the AI field. And when we bridge that gap, we can actually make the clinical impact. And it starts with a few basics. And I will show you in this presentation a couple of examples that projects that we are doing right now at the NKI. And the first thing that I would like to show you is our medical cockpit. This is actually an application that we developed together with DD Care. You can also visit them here at ICT&health. And this application really nicely shows out the care pathways, how they are developed and designed in the Netherlands Cancer Institute. You can see all the different stepping stones that the patient has to go through within their patient journey. And by really defining this basis, you can actually implement AI technology later, because it's important that every initiative that you have fits in within that patient journey. It should fit in care pathway, and there are of course many key elements that you need to organize before you can have success. And we're currently writing a position paper with all the core cancer centers in Europe, and I would advise you to read this paper when it comes out. And many dimensions are critical, but there's one that I want to highlight, and that's clinical validation. And that's actually what we like to do in the Netherlands Cancer Institute. We perform a lot of research, so everything we bring into practice is clinically validated, is tested. And two examples that I would like to highlight that we have brought from bench to bedside are one project in radiology and one project where we are using generative AI to create the consultation room of the future, decreasing the registrational burden for healthcare professionals like me, which is very much needed to create extra time for the patient, just as our minister just mentioned. What you see here, so this is actually work from my colleagues, Kevin Groot-Lipman and Laurens Top, is an axial slide of a chest CT scan of a patient with mesothelioma, which is asbestos cancer. And traditionally, if you want to measure treatment response, you need to actually draw within the CT scans the size of the tumor and measure by hand if the patient is responding to your treatment, whether or not the tumor is stable, progressive, or is actually declining. But with AI, we can automatically segment the tumor volume, as you can see here in this video. So with one press on the button, the tumor is extrapolated in 3D from the CT scan, and instantaneously you know, by comparison to the previous measurement, if your patient is responding. And this will save heaps of time for the radiologists. They have high volume work. There's obviously a shortage on personnel. And what you can see here is that this patient is treated with several modalities, so starting with traditional chemotherapy and ending with immunotherapy, and the according responses to the therapy are automatically measured with the AI modules. The next example I want to show you is the consultation room of the future. This is a project, as with the previous project, we are doing together with Kaiko, which was already mentioned. I would really suggest you have a look at their stand and also listen to their very interesting story from Nana Abe and Vele Strube. But with this consultation room, we really want to change our work. So, can I go back one slide? Thank you. Maybe start the video. There was a video when we tested. There's a video, 100% sure. Ah, that's a shame. Can you still fix it? Because we just, no? Impossible? Okay, it's a 2-minute video. Well, then I'll explain you what we have tried to show you. What we are doing with generative AI is that we are really changing our work, as I mentioned. So right now, when I'm seeing my patients, especially new patients in the outpatients clinic, I have to look at all the referral letters. I need to read the radiology report, I need to read the pathology report, I need to read the referral letter, and it's costing me a lot of time. And I need to process all this information and then manually retype it into my electronic health record. And with our new application that we built with Kaiko and also validated in the PhD project with Willemijn van Koevoorde, we can actually organize this with one press on the button. So we press the button, and what happens is that we see an overview of the information that we need. And in the overview, we can see the oncological history, we can see the reason for referral, we can see the radiology results, and ultimately, with one press on the second button, this is automatically transferred into the electronic health record in the right fields. So that is a major step. I now not need to hand type in the electronic health record, but I can actually press a few buttons and it's automatically pasted in my EHR. And the next step is that because of our very robust infrastructure, we can combine all the data sources. So I can also, for my MDT preparation, which is the multidisciplinary team meeting, we sit together with all the doctors. I can actually activate my AI tool, and all the data sources are combined. So I can see my radiology slides, I can see my pathology data, I can see my history from the consultation room, and it all comes together in one. And when we have all this information, we now no longer need to put all the time in preparing for these MDT meetings. It is just there. And I can also chat with my scans, ask if there is a potential aggressive tumor growth. I can see the lymph nodes that are pathologically enlarged, and this really helps me to save time. And I'm sure we can show you the video later at the stand with Kaiko, so please, if you're interested, have a look. It's a shame I couldn't show you now. But I'll give the word to Edgar, who will elaborate a little bit more on the organization at the NKI. Thank you.
Thanks, Richard. Thanks, Richard. And it's really a pity because there was a lot of time put into making this video, this demonstration. Also at 11:30, Keiko has a slot in room 3. Really go and visit them to see what's going on there. What we're going for is really a systemic change we would like to realize. We would like to focus on how do we really gonna make a difference and deliver our care in a more effective way. So yes, the tools are utterly important, technology. I will not deny that. I think it's needed. But before we start talking about tools, I would like to talk about our approach. It should be centered around the human. It's very focused on people. And in the people, it's not only the patients, but it's also the care providers, the specialists, the nurses, and the staff around it, and all the people that are needed as part of this patient journey to deliver this care that is needed. So our starting point is the people. So these people need to collaborate and work together in this patient journey, hence a process. So how do we work today and how do we want to work in the future? Where do we see the bottlenecks? And tools like Richard just showed, and also other tools that are out there with other hospitals or commercial partners that are available, we would like to implement them. We would like to look at them. Because for us, we look at innovation for the long term, but we look at impact on the short term. And when we talk about the digital transformation, and yes, I like catchy stuff and new innovations, and I'll definitely keep following that, but we're utterly focused on driving impact in the next 2 to 3 years. So what we do is trying to make that systemic shift. We want to do a lot of things at the same time. Like many hospitals, you also have a lot of work going on in your IT department. If it's a new electronic health record update with all of the other programs aside, or maybe a new move or a new build of the hospital. It all needs to go hand in hand. You can't do one without the other. So you need to collaborate in your hospital, but also outside your hospital. And it's not a black and white thing we can't do or we can do. We should work together and look at, okay, how can we face things? How can we look at timing? How can we look at the scope? How can we break it down into smaller pieces so we can keep moving forward on all of these different pieces? So in this gray area, we can find each other internally, but also externally. So which help can we get from partners? And again, partners is not just a commercial partner, but there's also other hospitals who've done it before. We're very proud to say, hey, we want to copy some of the stuff that's been happening out there in other hospitals. And I think that for us is a key game changer, that yes, we're very focused on research as the Netherlands Cancer Institute. But now we're also looking at how can we drive this impact on the short term. So we have a couple of focus areas. It's all around interoperability. How can we work together from a process perspective, but also from a data perspective? Data, obviously, and I will not go into details on that, obviously is the source of all things, where our IT department, where we've developed a great cloud environment with a data lakehouse. There's a whole different topic on that, but there's a couple of topics I want to highlight on the focus that we're in. The first one is a team where we want to look at efficient diagnostic and treatment. And basically how we call it internally as well is very much around value-based healthcare. How do we look at impact, the outcome? So there's two type of initiatives. First of all, we want to support data-driven decision-making with the patient and the specialist. How can we do that more effectively? Yes, we do that today already, but how can we do that more effectively with them based on data, on tools that are out there? Might be AI. Some of them are just questionnaires. Some of them are just information we share, present to the patient in a very friendly way. So it's not new innovation, but it's innovative enough to put it in a patient care pathway so we can deliver better care. Second one is focus on effective diagnostic and personalized treatment. Internally, we call it AI for imaging. It's just what research showed is one great example, but very much focused on how can we use the algorithms to do a lot of the work, the manual work we've been doing before. And then the second theme is very much on how can we digitize, or the digitalization of our patient journey. So e-health, home, taking care of the patient at home, communicating with the patient at home. How can we do things more remotely? How can we prepare the patient better before the patient comes in? And of course, wouldn't we all want to do that, minimizing the administrative burden? And actually that's kind of connected in all of the previous themes as well. So the simple things, let's avoid the retyping. Let's make the right connections all together. There's a lot of other stuff going on around it, but this is our key focus area that we really want to drive the impact in our hospital in the next few years. So ultimately, 2 to 3 years, as I mentioned, it's about directly improving it. And I want to look at the entire Antoni van Leeuwenhoek team as like, how can we measure that we improved? How can we measure that we're more effective? And how can we measure that we have improved the experience, not only for our patients, but also for our staff, who in some cases are very thin-stretched or extremely stretched and thin-spread around the organization to provide the care that our patients need. And I think for us, that's the key challenge. I want to make it measurable, because when you make it measurable, you can see where you're successful or where you need to pivot. And for closing off, this for me is also a start of a dialogue, because one thing we know for sure, we can't do it by ourselves. And we all consider that we're all good and we all know a lot of stuff, but we can't do it by ourselves. So we have 3 key elements that definitely we'd like to open a dialogue with. First of all, we think it should be a holistic approach around the patient care pathway. We think it's important to really think about the ecosystem. Your patient, the care provider, but also other hospitals. I think it's about 60 to 65% of the patients we see are referrals from other hospitals. Wouldn't it be great if we can better collaborate in today getting an email with the PDF files and somebody manually has to put them in our electronic health record? And wouldn't it be great if we can work together and think about better ways of providing the care in a more effective way? And the foundation of this all, it starts with us. What can we control ourselves directly is our own organizations, the way how we behave, our attitude. So it's around our culture, and I call it governance. How are we organized? Who's responsible for what part? And who takes ownership to drive this change? And also owns it if something's not going the way we kind of like intended it to go, because it looked good on the slide, but it didn't really work. But we really need to collaborate on that, okay? So because we measure it, okay, this means we need to change it. So for me, this is an open invitation to start a dialogue with me and many of my colleagues to really drive change, systemic change for Antoni van Leeuwenhoek, but also supporting each other in your organizations. And for that, I'd like to thank you.
I'm so sorry. Technique is something, not so far away, please. Technique is difficult. We checked it this morning and it went well downstairs, but now here something went wrong. Sorry for that. I was wondering, Harry, when you came in and you see now the situation, did you feel already change in the Antoni van Leeuwenhoek?
I just started, so yeah, there's a change because I can cooperate now with people who I was a patient, I'm still a patient, I'm now a colleague of the people who help me. So that's a change for me, and yeah, I notice some differences because I'm already involved with some on a strategic level to participate as a patient. So that's really great.
Yeah.
To have an inside look of what's going on for the patient.
Yeah.
Absolutely.
What type of feedback do patients give you?
Well, maybe.
Oh yeah, sorry.
So, in general, in the Cancer Institute, we actually get a lot of positive feedback, and I think, at least that's my experience, I think patients often say that the Cancer Institute is there from the cradle to the grave. So we basically treat patients from the start all the way until, you know, the final phase of life, and that's also something we would really like to emphasize, that it's very important that it's about care. It's not about, you know, doing the trick and then send the patients away. So I think there's many things we can improve, but by focusing on the patient journey and giving people like Harry a voice, we can keep on improving.
Okay. Another question for me is, and I take the other microphone to change it because you need that one for the room. Oop. You talked about validation. How do you validate? I don't think you validate yourself.
Well, that's true, and it's very difficult. And of course, we have a lot of experience with research, and we involve methodologists and statisticians to help us to set up, you know, proper research. But for example, the consultation room of the future, if you want your generative AI to help you and to do all the work automatically, you of course need to make sure that your model is doing what it's supposed to do. So first, you should set a standard. And that's what we're doing with Willemijn's research. We ask many healthcare professionals.
Also from outside the hospital?
For the trial that we have currently done, many just inside, but we can of course collaborate with other institutes in future. You set a standard, and then you check on different measures if the LLM is actually doing what it's supposed to do, and then you can determine scores such as precision and recall, etc., etc., and it tells you if it's performing the way it should. And you can also train your large language model with prompt engineering, and ultimately also using the data that we have so much at the Netherlands Cancer Institute. So this is key, because of course as a doctor I want to make sure that what I see is clear and it makes sense and it's actually true and it's not hallucinating.
It is not yet peer reviewed.
The publication still has to be published, that's correct. But the results are there and it's a sound setup. Yeah, of course. Yeah.
Shall we change?
That's fine.
I was wondering, you came from a multinational to a hospital, which is a completely different situation, also for you.
Yeah.
You told me that.
True.
And I was wondering, the path we take now at the moment, because everybody expects, well, we can speed up. The ego environment where you are in, how do you feel, is it possible in hospital to speed up if you organize it in this way?
It's a very good question. I do believe we can speed up, because I'm a strong believer in driving change, but ultimately you got to find what motivates each individual or a group of individuals. So what I've learned very much is, because everybody keeps talking about the power of the specialists and stuff, it's not about the power, it's about how they've been used, how they've been trained, and how to take care of a patient. So you fully need to understand what drives and motivates a specialist, a doctor, a surgeon, like Richard, or also a nurse. And the better we understand them, what drives them, and what's in it for them, instead of, I got this great innovation, it has all these functions and features, look, and it will save you time or will make things better.
Yeah.
But make the connection from their side. So what are their needs? What do they struggle with? And take that as a starting point. And I think there is one of the keys to really speed up that change.
So you have to take into account every detail, but also every detail of the process of the professionals themselves.
Yes.
Okay.
Yes.
Light, please. Time for you. Who has a question? Wave like this, otherwise I don't see it. It's rather strange because you are with so many. You have to wave and then I can see you. Yeah, I see you over there. Can you stand up, please?
Yes, I was wondering, because in this, as I'm a doctor myself, and I would be a little afraid if generative AI made a summary of a referral I got, and something was wrong with it in a system that I don't fully understand, that I would be disciplinary liable. You as a doctor, how much do you check, or do you fully trust the system?
Good question.
Yeah, that's a great question, spot on, and that's of course something we struggled with as well, and we are still struggling with. But what we've done so far with all the technology that we are trying to implement is that we're keeping the health professional in the loop. So before it comes into my electronic health record, I need to click on a button that says, okay, I'm happy with this summary. It can go in the fields I want it to go into, and then I can, of course, double check. And what we've built in this system with Kaiko is that we can actually check the source. So when I read the summary and maybe there's something that doesn't make sense, I can check, I can click. Of course, I wanted to show you in the video, but you can check it later, please. You can see the actual PDF of the referral with the coffee stain on it. So you can check whether or not it makes sense. But great question, and that's something you really have to be precise on and keep on checking, because of course, we still need to use our common sense.
Yeah, don't believe the LLM always. Please. Close to the mouse, please.
Hi, my name is Dionne from Visma Connect. My question is, I recently learned about swarm AI. That means that you take a language model and you put it in a sort of sandbox and you learn from there. What model is used for this solution that you have currently?
Well, first of all, again, together with Geico and our ICT department, we've really changed our data infrastructure. So currently we have a data lakehouse and an NKI tenant, and we can actually deploy our own large language models, or we can deploy open source LLMs within our own infrastructure. And what we've used is actually the Mistral for this project. So this model was validated, and to go on this, we can actually now also with automatic validation quickly check new models. So we're using LLMs as a judge because of course the developments are going really rapid. So probably the model that we've used for our clinical validation will be changed for a new model in future, which can then of course on its turn be validated with another LLM as a judge.
Thank you so much, gentlemen, for your contribution today.
Thank you.
Ladies and gentlemen, Antoni van Leeuwenhoek. One of the main partners of ICT&health is the hospital next door. You have to be good friends, isn't it? And I'm thrilled that Helen Mertens is back again. She was here last year, and she is the president of the executive board, and she was really a driver of change. She wanted to change her hospital. So, Helen, please join me. I was wondering, do you feel, and is there already common ground for transformation in your hospital? Take us to the transformation you're in, please.
Yeah, there are a lot of them, and I will show you.
Yeah, give her a big applause.
Thank you very much, and thank you for this introduction. I'm really very glad to be back again, and I all wish you a very, very warm welcome to my hometown, Maastricht. And I'm really honored to give a keynote lecture here today, especially in the same session as our Minister of Health, Minister Agema. And I would like to go back to that talk with you, because I agree a lot of concerns and all the challenges she mentioned. I agree with all the promises of the digital revolution and all the AI and all the digital transformation as a promise. But I do not agree with her that it's an easy game changer, that the digital transformation turns out fine automatically. I really think we all have to work on that. We have to work hard on that, on digital things, on technical things, technical issues, solutions, digital solutions, but also on culture and also on behavior. And the last question was about trust in the system. How can we build trust on our professional to use it and also our patients to use it? So I think with all the solutions we can see here on stage and on the floor, I think it's time for a reality check. So please join me. But first we start where we are. We are now. You came in this morning with the convention center, beautiful convention center, the MAC. It's one part of our Maastricht Health Campus. And that's very close to our organization. This is my organization, the University Hospital of Maastricht, and within we have the Organization for Radiotherapy, and that's very close to the University of Maastricht, the Faculty of Health, Medicine and Life Sciences, and also the Faculty of Science and Engineering. And we also have to think about business partners. Medtronic, for example, Medace. And what we do, we live together and we work together. We collaborate, and because of that collaboration, we accelerate in the Brightland Maastricht Health Campus. And when you, in these 3 days, do like we meet each other, we make connections, we make collaboration, we get inspired by each other. When you do the same in these 3 days of the Congress, I know for sure this is the very best place for this Congress. It was last year, it is this year, and I hope, Tom, it will be in many years from now. But then to the reality check. Please join me in. We know, also as a doctor, we know about patients, diagnostics and treatment. So imagine our healthcare system is like a patient that is struggling with his being alert, has pain, is struggling with systemic imbalances, a patient, and we imagine the healthcare is like that patient. And when we like to improve our healthcare system and get rid of all the challenges we have and all the concerns we have to treat our system like doctors treat our patients. So we need some vital signs of our healthcare system. And I think we have 4 of them. We have the accessibility of our healthcare system, the quality, of course the sustainability, and also we have to pay for it, the affordability. And I think with all the solutions we see here and all the possibilities, we have to think whether this innovation really adds to this vital signs of our healthcare system. And patients always choose for the best treatment of our patients. No overtreatment, no undertreatment, and I think we also have to do that with our innovation. We always have to ask ourselves the question, is this innovation really benefits our patients, also solve one of all the vital signs of our healthcare system? And first I would like, when I look for innovation, I would like to share my excitement. I'm really enthusiastic of all the things on stage here and also on the floor. There are a lot of innovation I never have heard of. And there are also a lot of innovation I met here that I never had thought that could have impact on treatment and benefits for patients or the healthcare system. I'm really excited about that. But enthusiasm does not heal our healthcare system. We really have to be realistic about the time, about all the solutions they are offered. And I think really we have to check whether they help us in our healthcare challenges and also helps on the patient. Because the innovation is not a goal at itself. So what is the goal? For me, healthcare is not only curing diseases. For me, healthcare is about empowering patients and supporting healthcare professionals. And I think this is the goal we have to have in mind. Healthcare is about the connection between patients and healthcare professionals. It's about the connection of knowledge and expertise with compassion. And I think all the innovations we will do have to add on that vital connection. So let's check all these vital signs of our healthcare system. When we look at the cost, we see that the cost almost doubled in the last decades. And that's not only because of the demand on healthcare is rising because of the elderly people, or because of the rising estimated life expectancy. It's also because our knowledge about health and healthcare increases. We use more expensive drugs. We use much more expensive technology. And also this is a cause of all the increase in our healthcare cost. And when we do not transform our healthcare system, and we do like we did it yesterday, our system is not affordable, like we know it these days. And the second one was the accessibility. What we see is that the demand of healthcare is totally increasing. And that's because of the elderly, of course, that's what also the minister has mentioned, but also because the number of patients with at least one chronic disease is increasing as well, tremendously increasing. And with the rising demand of healthcare, we have another challenge, that's a shortage of personnel, and that's not a good combination, of course. And when we look at the numbers, we see that in about 10 years, we face a lack of almost 3,000 colleagues in healthcare. And we will have a shortage of almost 83,000 nurses in healthcare. And healthcare and nurses are by far the biggest type of healthcare professionals. And the shortage there, we really have to prepare for that. And that's also a reason why I'm glad that tomorrow we have a day always focused on the nursery and the nursery innovations. But that shortens when we don't transform our healthcare system. Really, our healthcare as it is today, it's not accessible anymore. So in the Maastricht UMC Plus, our organization, we have a strategy to tackle all our challenges. And that means healthy living. And healthy living is about a healthy future and also about a sustainable healthcare. And in that strategic program, we have 5 different strategy programs. Prevention and vitality, for example, also very important in healthcare. And another program is the connecting between scientific research, education and healthcare. But for today, we will focus on the left one, our healthcare of the future. And that program is about redesigning pathways for patient care. We check what's digital, what kind of possibilities in there, what do we really have to redefine in the healthcare program of the patient. And also in this program, we make proper agreements about data, because using data is very important to transform our healthcare system. So in our organization, we made a digital healthcare strategy, and also we invested on data infrastructure. We invested in data-driven work, in digitalization and in healthcare processes. We make proper agreements, how we administer data, how we can single administration build multiple use of our data. And I think we really need that for the transformation in healthcare and to improve our healthcare. So the data is really the basis for that. And our team of the Innovation Lab made the digital strategy about digital innovation, about digital tools. And this strategy is to empower the patients, to empower the patient to play an active role in their well-being, but also if ill, they can play an active role in all the choices for diagnostics and their treatments. And I think also this is very important, to take patients and all the people in the city with us on our way and on the digital transformation. Let's look at the data and let's look about the nationwide infrastructure. I think this infrastructure, like a vascular system in a patient, I think we really have to focus on that, because that's really crucial to improve the healthcare, that the data infrastructure will be better than it is now. And I believe that in the Netherlands, we are on the very beginning of the right track. And I hope that all the healthcare insurers and also the government will take their responsibility to really invest and focus on this. We have to encourage the government to make the right decision about this. And other countries that are much further, they have good appointments and good agreement about our data network. But in my opinion, in the Netherlands, there are too many tafels. That's called so-called the tables of discussion and the table of panels, with a lot of chairs and people who are sitting there with their own individual interest. We lack a nationwide vision and also conclusions and decisions about a nationwide network. And this is really crucial to improve our healthcare system. And we work on the floor, you can see a lot of standards. So I think we are a step in the good way. We have some standards, and also the initiative of the university hospitals, Cumulus and also Health RI, I really think they will improve our healthcare system, and they act and react on our vital signs that we do in the reality check. Fire, perhaps, there's really good standards, so I think this is the very step forward. And also I think the electronic patient charts will help us. And recently in November, we implemented EPIC, and also for us organization, there's really a step forward for all the data and the data infrastructure. So we have to reuse data. We have to reuse them for not only the treatment in the whole chain, but also for scientific research and also to build the foundation for AI and for the digital revolution. And from patient data to organizational data. And I'm really enthusiastic about that because our team of our integrated capacity management provides real-time data about capacity in our hospital, but also about capacity in our region. And they can really proper plan all the operation and all the admission to our hospital. And this will help, and this also helps on the vital signs of our healthcare system. Because with their action, we have less days of admission at the hospital. We also have reduction of waiting lists. We use our capacity much in a better way, and it also reduces a lot of cost and frustration of our healthcare profession. They don't have to make many phone calls to find a bed in the evening. So also that's important. Dus doing the reality check, I'm very enthusiastic about these data and using these data. So organizations, I think, and the governance are beginning to coming in the right way. I'm slightly positive about that. They know the urgency and they try to invest in the real innovation. And I think we have to encourage them to ask themselves always the question, is this innovation really, does that benefit to the system, to the patient, or is it an innovation at the goal by itself? But, and then we do a reality check on the profession. I'm positive, slightly positive about the organization. And what about the professionals? I'm sure that all professionals will add on the treatment for patients and will treat and also benefits for the healthcare system. All do. And some doctors are doing it very well. But there are also professionals that could do it better. And I think we have to encourage them to use data and to administer data in the right way, especially in the emergency room. It's very difficult when it's busy in the nighttime to administer our data in the right way. So we can use the data, we can reuse the data, and also give the good information for all the AI developments. But I'm not sad about that. I really see also the positive things. And I would share some beautiful and excellent examples with you. For example, this example of an ENT specialist, of Mark van Hoof with his team of the Maastricht and the Radboud University. They built a visualization of a tumor, this kind of cochlea, of an inner ear. And with this visualization, they can show it on the patient, so the patient better understands what's wrong. And they also empower the patient to talk about the treatments and all the decisions they are made. So this also helps on these vital signs. And another very excellent example is the Telecheck AF. And that was built by Dominique Lins, one of our cardiologists, with his team. And we have a lot of patients with this chronic disease, atrial fibrillation. And with the build and with the use of an application, we can remote monitoring our patients, even without coming to our hospital. We can show the heart rhythm, and we can see the atrial fibrillation in patients nationwide, Europe-wide, and even worldwide, if you like. And what we see, this chronic disease, what we see using this app and using this application, that the quality of life is better, patient care, patient satisfaction is better, and a tremendous reduction of cost, and also a tremendous reduction of all the interventions by healthcare professionals. So this really adds to the system and to the improvement and the transformation that we need. Another example I would like to share, and it's also these days, is the digital twin concept. And this is also from the cardiologists. They build, with the individual characteristics of a patient, they build a virtual heart. And on that virtual heart, they can try out some interventions and some scenarios of treatment. So also this will help, and this will reduce in costs and give in better treatments. And there are many, many, many more very good examples where I'm proud of, but I don't have the time to share them all, but I would add on all the good examples also the examples for nursery. And tomorrow there will be a day with focus on this congress on all the innovation in nurseries. And nurses represent the largest group within healthcare. So the shortage of this personnel, we really have to prepare for that. So I hope you will get inspired tomorrow with a lot of innovation in nursery, and also will get inspired, but also take them with, skill them up, because that's always something we have to do, and also the Minister of Health mentioned about it. There are really much more excellent examples, and exams are so proud of, but there's not much time, I think. But for now, I hope you really get inspired on the stage, and you see some exams, take them home, scale them up, and really, I hope you will be prepared for future. Thank you very much.
Thank you, Helen. Your nurses play a strong role, isn't it, in the innovation? Because I think one of them was also invented in your own house by the nurses, isn't it?
Yes, yes, for sure. Because when you see what makes impact on the experience of patients in the hospital and also outside the hospital, that's most of the time all the nurses. And because of our challenge in the shortage of personnel, we really have to add nurses on all the decisions we make and all the transformation in healthcare. So it's really important that nurses are being involved.
Yeah. And the digital twins, are they still under research, or you use them already in the daily practice?
Yeah, both of it. We saw some robots, and we use them in daily practice. And also we have some experiments with it, but also I think, yeah, most of you have some robotisering in healthcare, but also in the nursery. I think they can be helpful.
Okay. You mentioned, well, you were a little bit, oh God, those tables. We have to discuss together the future of healthcare. But I was wondering, you talked also about the need of a nationwide vision. That was the reason for the tables, isn't it? But it doesn't speed up the tables?
No, I think it doesn't speed up with all the tables and all the discussion. I think we better stop all the discussion, all the chairs on the table go away. But we really have to encourage our government to make the real decision. We really need that nationwide network.
Like Australia, for instance.
Yeah, for instance, and a lot of countries with good examples. And I think we don't have one electronic patient chart for the whole nation. That's a pity, but that's okay, because we can collaborate all the data, then it's okay. And we can have change and rechange of data. That's the most important thing. And we have different systems, but I think it's when we have the chance to share all the data, then it's okay.
Shall we go to the audience? Rooms, lights, please. Who will wave to me? And then I come to you. Kijk. Please.
My question. We had a wonderful presentation
Sorry,
by
who are you?
Annelies van den Berg, patiëntenregie. Would you appoint a chief patients officer, like Antoni van Leeuwenhoek, in this turbulence of all these changes that you are so energetically realizing? I'm sure you're going to realize it. Would you put in a chief patients officer? I think it's a brilliant idea.
Yeah, that's a very good point, because I didn't talk about that. But of course, patient has to be involved in this. And what I mentioned is we have to empower our patients also because patient participation will lead to better satisfaction, better outcomes, better cost, and also in the all digital transformation, we have to involve patients. And we also have to take care that all the digital transformation is inclusive. Anybody who likes to go within and goes and join, we also make it possible. And one of our Citrin projects about this also is about this, and the inclusiveness of the use of digital innovation and digital tools.
Okay. Other questions, ladies and gentlemen? Yeah. I saw somebody waving over here. Hello, who are you?
Hello, I'm Vivian van der Kommet from Raad MUMC. You just talked about that there was no problem with the different APDs in the Netherlands. I think there is, and I think we should, in a small country as the Netherlands, it's hardly to explain that there are so many different EPDs, and they do not connect, because we get a lot of referrals from during the Netherlands, and we can't see in the other EPDs. How can hospitals like the UMC Utrecht and also, of course, other hospitals do to go to the ministry and say we need one, because we are already for years talking about we should probably have one, but nothing changes.
Helen,
Yeah.
should we have one, like one app for everybody?
Yeah, I really...
Yeah. Okay, come on.
I think we are too late for one EPD for the whole country. And I agree, we are a very small country. But I think that's not important, because we have to work on the connection of all these data and all these apps and things like that. And I think when it's technical possible,
Make
and
them
it
interoperable.
is, we know it, but we also have to be critical about our use and our behavior in administer data, and also the use of all the apps and all things like that. When we really ask ourselves the question, is there really attack to the four vital health of our healthcare system, and only do that and put our money on that, I think we really can go steps further.
I saw somebody clapping here for we don't need one. But I see Femi upstairs. Femi, I will come to you. Oop. Oh, you don't clap for me. Oh, then you don't get a question. Come on, stand up, please.
Yes. I'm just thinking, do we need one electronic patient file system, or do we need to centralize data and create frameworks that enable partners, APD partners, to use these standards to disclose data? And what's the role of the ministry? I don't know if you have the answer, but we probably should talk about this.
Good question.
I think there are many
You have
solutions,
supporters, Femi.
but I think the way that we have chosen in the Netherlands is okay. The way that we go, not with one centralized database of all patients' data, but leave the data at the hospitals or leave the data at the places outside of with the patients, and just go with your research question or with the information you need to that place. So hold all the data on the place they are, and don't put your money on building a centralized database. And I think the infrastructure as we have, when we better share and better connect with all these data, that's a very good possibility for the Netherlands.
Another question.
Hilde Bouwen from TNO. We did a project on exactly that, so trying to integrate data from different resources in a federated way, similar to the swan learning referred to before. And what we have seen there is quite shocking. The data quality itself is just a major issue. It's not about the connectivity, it's really about the data at the source. And it's not the data. The main problem is that it's not about a patient journey, which is the subject today. But the patient journey is not stored there. What is stored in the system is the fact that data has to be paid for, care has to be paid for. And I'm really wondering what we will do there. How are we going to resolve that question? How are we going to store the patient journey so that we can generate a learning care situation, learning care solution in the Netherlands.
So what you mean, yeah, you can applaud, of course. What you mean is it's only the data for the insurance companies and not the data for the specialists, the nurses, etc.
And for the patients.
And
So
for
we
the
were
patients
talking about
themselves.
patients' quality of life and value-based healthcare. Then we really should think about what is the quality of the individual and what is the patient really getting. Because if there is twice in 3 days an indication that a treatment has been given and we know that it's toxic, that's probably because it's not given the first time, but it just went, it's just thrown away. And that is then still reported in the records. So we really should think about that as well. And of course, be very careful that we do not increase the administrative burden. But that's really a question that we should ask ourselves. How are we going to resolve this data quality issue?
I think that's a very good idea to talk on the tables. Which data do we do? And the quality of data should be on a higher level.
Yeah, thank you very much for this point. I think that's very important. And there is not one single answer on that kind of question. And we need all the power from all the patients here. And we also need our own criticism. Do we really do the good things that benefits our things? And we have to encourage also the healthcare insurances also to get this importance and to focus on this. And I think then with all of us, we will make progress on that.
Thank you. Still a lot of work to be done, Helen.
So, I'm glad to.
It's time for coffee. Pick up everything. I think data is one of our main questions to be solved. Which data do we collect and who puts it in the data and how is it interconnected and interoperable? Thank you so much. I see you in the afternoon.